Without further ado, let us get to know our first speaker who will kickstart this evening's lecture about practical guidelines in the diagnosis and management of NAFLD. So our speaker has obtained his Doctor of Medicine at the University of Santo Tomas, Faculty of Medicine and Surgery, and is also currently an assistant professor in the same faculty. Our speaker is also the Chief of Section of Gastroenterology at the UST Faculty of Medicine and Surgery and Section of Gastroenterology at the UST Hospital. He is also the head of the endoscopy unit and section of GI oncology of the Benavides Cancer Institute at UST Hospital. He is also the a current board of director of the Philippine Society of Digestive Endoscopy. A mentor and a senior to me. So being as a young gastroenterologist myself, he is one of those whom I look up to as well. So everyone, let us all welcome our first speaker for this lecture, Dr. Frederick D. Dr. D.
Thank you, Jello. Thank you very much for your very kind introduction. So let me greet everyone a pleasant evening. And I would like to first begin by thanking Westmont for giving me this opportunity to share my thoughts on non-alcoholic fatty liver disease. Recently, when we talk about liver diseases, we know now that fatty liver diseases is probably going prime time. And this is because for a lot of reasons. Now, partly, when we talk about liver diseases, we were thinking of viral hepatitis before. And when we talk about hepatitis C currently, we have wonderful DAAs, medicine that can achieve sustained viral response in more than 98%, no matter what the genotype is. And therefore, probably when we talk about hepatitis C, it's not really so much. Apart from that, in the country, we know that hepatitis B being one of the most common diseases, we know that it affects a good number of Filipinos. However, because of the wonderful medicine again that we have medicine that is very potent, and because of this potent medicine, this nucleoside analog, the resistance rate to the use of this medicine is very low, and hence hepatitis B is really under control. And therefore, for a lot of reasons, non-alcoholic fatty liver disease is becoming one of the hottest topic now, receiving much attention. Not only attention, we are giving more efforts to this. Apart from the effort, we are talking about NAFLD more often. So, but that is just part of the reason why we should be talking about NAFLD. For other reasons, we have to look at the incidence. We know that the incidence of NAFLD seems to be rising. And this may mirror the number of patients with diabetes or those patients who are obese, or those patients, of course, who have metabolic syndrome. We know that majority of patients who presents with NAFLD, they are silent. They don't feel anything. However, if left untreated over time, this disease may become fatal. And therefore, proper management and of course intervention earlier on would be great to be able to reduce mortality and morbidity associated with this probably reversible disease. We know when we talk about NAFLD, there are associated comorbidities, and this increases the mortality among patients diagnosed to have NAFLD. And right now, we keep on talking about metabolic syndrome. We have patients with diabetes, hypertension. We have patients with high triglyceride, low HDL, obesity. We know that metabolic syndrome right now cannot be cured. However, with medicine and with lifestyle modification, it can be controlled. NAFLD in the past was not really thought of as a killer disease, but right now in the US, at least in the US, the number one indication for liver transplantation is not related to alcoholic liver disease, not even for viral hepatitis C, but rather the number one indication for liver transplantation now is NAFLD. And lastly, we know that the science for NAFLD is progressive as new therapies are being developed. And here, these are some of the reasons why NAFLD needs to be talked about. So the objectives of this short talk would be to discuss with you whether should we use from a practical standpoint NAFLD or should we use MAFLD or the newly coined term metabolic dysfunction associated fatty liver disease. How do we diagnose NAFLD or MAFLD and its sequelae? And a little bit of discussion on lean NAFLD, which I will inject from time to time. Review the current management of NAFLD or MAFLD and explore safe options for the treatment of NAFLD. Now for this talk, because MAFLD is quite new, this is a newly coined term, I would use this interchangeably because there are more data for NAFLD as compared to MAFLD, especially when you talk about researches. So therefore, for this talk, when I say NAFLD or MAFLD, I mean the same thing. So histologically, when we diagnose non-alcoholic fatty liver disease, we mean there's 10% of the hepatocytes contains fat in the form of triglyceride. So therefore, by this alone, one would say that we really need biopsy to be able to diagnose non-alcoholic fatty liver disease. Maybe because ultrasound only detects fat in the liver if the fat content is more than 30%, and therefore less than 30%, the ultrasound might miss. Or probably for some individual who are diabetic and they don't have fatty liver disease, by ultrasound, that only means that the ultrasound was not able to detect it. It doesn't mean there's no fatty liver disease. Likewise, we use ultrasonography or some other imaging, let's say CT scan or even MRI, for evidence of hepatic steatosis. And traditionally, if we look at the diagnosis that we are using before, there should be no other causes for secondary fat accumulation. And we know now that NAFLD is associated with metabolic risk factors such as obesity, diabetes, and dyslipidemia. And clearly, there's a big overlap between non-alcoholic fatty liver disease and alcoholic fatty liver disease, even if we do biopsy. And therefore, this should be taken out of the equation, meaning to say individuals, men shouldn't be drinking more than 21 drinks per week, and women not more than 14 drinks per week. So, to get to my first point, from NAFLD to MAFLD, a group of hepatologists recently suggesting to change the term of NAFLD to metabolic dysfunction associated fatty liver disease. The basis for this, they are saying that dual etiology of fatty liver disease may actually happen. Therefore, what they're trying to say is that any particular individual may have metabolic syndrome, they may be alcoholic, they may have viral hepatitis all at the same time. And therefore, rather than putting NAFLD as a diagnosis of exclusion, they want a diagnosis of inclusion. Meaning to say, we have a certain set of criteria to say that the patient may actually have metabolic dysfunction associated fatty liver disease. In the past, when we talk about secondary hepatic steatosis, here are some of the causes. It can be nutritional, it can be secondary to drugs, some other metabolic or genetic disorders, or even some other disease which may include inflammation of the gut, like patients with bacterial overgrowth, inflammatory bowel disease, which can all cause secondary hepatic steatosis. But on the other hand, when we talk about MAFLD, we are trying to change this, and they are suggesting to change this to alternative causes of hepatic steatosis. Therefore, what they're just trying to say is that all of this disorder may coexist on some individual with metabolic dysfunction associated fatty liver disease. So let me go over with you with regards to the criteria to diagnose NAFLD. No question, in patients with hepatic steatosis, by whatever means, by imaging technique, blood biomarker score, or by liver histology, if they are overweight and they have type 2 diabetes, immediately you can diagnose as having metabolic dysfunction associated fatty liver disease. Just a gentle reminder that the BMI cutoff BMI among Asians is 23 kilogram per meter squared, unlike that of the Caucasian, which is a little bit higher. Now, the question therefore lies in what about those individuals who have normal weight or they are lean, and when you do imaging, they have fatty liver. Now, this is the benefit of using this metabolic dysfunction associated fatty liver disease, because even in this individual, if they have at least two of the following metabolic risk abnormalities, like the waist circumference, blood pressure that is high, elevated plasma triglyceride, low plasma HDL, they are pre-diabetic, they have problem in insulin resistance, or they have a plasma high sensitivity CR reactive protein that is greater than 2 milligram per liter. If at least two of them is present, then you can diagnose them as having metabolic dysfunction associated fatty liver disease. So how often do we find NAFLD, lean NAFLD, those individuals who have normal weight? Now, if you look at this map here, I'm just showing here in box in red, the Asian countries. Majority of Asian countries have a range of anywhere between 35 to 40%. So 35 to 40% of their NAFLD tends to be lean, except for this data from Malaysia. This is the outlier. The Malaysian data, 12.9%, which is actually 1/3 of the usual prevalence of lean NAFLD across the Asian continent. The exact reason, I don't know, but maybe we need to get our own data. But we have actually in our institution, which I will show you in a while. Now, one would assume that the mortality for patients who are obese should be greater as compared to those who are lean. And because we assume that obese is really not healthy, and we assume them to have a greater mortality or morbidity. Now, it's interesting because ironically, if you look at this data here coming from the same group of those who check this out, the cohort of patients that I have included here, the mortality rate among all-cause mortality for non-obese or lean is higher as compared to those who are obese. Likewise, cardiovascular-related mortality is 2 times greater as compared to those who are obese. If you look at the white line here as compared to the brown line. So again, showing that lean NAFLD is not really safe, and this individual may over time develop complications. Now, in our own institution, we did a this report by Dr. Stephen Wong comparing lean versus non-lean. It would appear probably, but this is only one data, that the number of patients or the percentage of lean NAFLD in the country is about 1%. So we actually mirror the one that is being presented by Malaysia, about 12%, and not really the entire Asian continent. And among these, although less patients have metabolic syndrome, diabetes, hypertension, cardiovascular disease, or dyslipidemia among the lean NAFLD, but I think just over time, these patients will develop this problem. So it's just a matter of time before this lean individual will develop metabolic syndrome. If we follow them over time, a good number of them will develop this metabolic syndrome. And this was shown clearly by some of the Japanese study wherein they followed a patient over time. So they look at patient with fatty liver and ultrasound, and they followed them up in 10 years' time. And lo and behold, what happened was, after 10 years, more patients were initially they have fatty liver and ultrasound did have metabolic syndrome after 10 years. So in the real world, how does NAFLD diagnosis compare with MAFLD? Well, if you look at this in the real world, it would appear that patients, when you diagnose them as having fatty liver disease, non-alcoholic or metabolic associated fatty liver disease, then most patients with MAFLD tends to have a more severe metabolic syndrome. They have more severe diabetes, they have greater hypertension, they have higher rate of hypertriglyceridemia, lower HDL, and so on and so forth. And the fibrosis score seems to be higher as well. So using MAFLD criteria, patients diagnosed tends to be older, have more metabolic disorders, and more severe liver damage. All right, so my take on this, from a practical standpoint, should we use NAFLD or should we use MAFLD? Well, MAFLD may be better to use practically, as patients may have other reasons for liver injury, meaning to say, we are not discounting metabolic dysfunction associated fatty liver disease because 2 or 3 etiology may happen at the same time. Likewise, this is a positive diagnosis now. Instead of a wastebasket diagnosis of saying someone as having fatty liver disease, we now can diagnose someone using a positive diagnosis based on the criteria. Likewise, MAFLD takes into consideration waist circumference as a risk factor, thereby including in the population patients with lean NAFLD. Because lean NAFLD, their weight might be normal, however, the configuration of their body might be may not be healthy. Fulfilling the criteria of MAFLD increases the probability of metabolic dysfunction, and this is clear. However, there are still some questions still in the air as where do we classify patients with fatty liver on imaging but without enough criteria for metabolic dysfunction. But I guess if we just follow them over time, maybe ask them to come back in 6 months to 1 year time, unless they change their lifestyle, probably this patient will clearly be diagnosed to have MAFLD over time. Now, I placed here last that I believe that research would favor more the diagnosis of NAFLD. And this is because when we are doing research, especially if you're going to treat something, we want to be sure on what we are treating. By putting MAFLD, 2 or 3 etiology, which one actually improved with the medicine that you gave? And that is a basic issue. Of course, we can just say that because we are treating diabetes, maybe we are, then of course we are saying that this is the reason why it improved, but that is just a speculation. So if you want to be sure about it, then probably we need to use NAFLD, ruling out all the other diseases if you are doing research. But clinically, I think MAFLD would be more practical. So definitely NAFLD over time is associated with cardiometabolic disorders, and there's a higher rate of cardiovascular disease, chronic kidney disease, and type 2 diabetes. Apart from this, because of the elevation of insulin and insulin resistance, then hepatic and extrahepatic cancer tends to be higher. Apart from that, we have other endocrine and obesity-related disorders. As you can see here, included are hypothyroidism, polycystic ovary syndrome, or PCOS, or obstructive sleep apnea. So, what happens to patients with NAFLD? Now, NAFLD, majority of them tends to have isolated just fatty liver disease, and they don't progress over time to cirrhosis. While one remains to have fatty liver and the 10% developing NASH, there's no concrete answer to this, and this is not really so clear at the moment. However, one may assume that probably some genetic factors may play a major role why one develops NASH and the majority only develops fatty liver disease. And of course, with the term steatohepatitis, then we are looking at activity. And there's activity, NASH cirrhosis tends to be higher and it occurs over time. And apart from this, a good number of patients with NASH may directly go to cirrhosis, bypassing the stage of NASH cirrhosis. And this is a concern now because previously what we are saying is that for hepatitis B, yes, this can happen, non-cirrhotic patients developing HCC. But right now, even for patients with NAFLD, especially if they have NASH, this can actually happen. Now, why is it important to diagnose NASH and advanced fibrosis? If you look at this US data here, you will see here that majority of patients in the US tends to have NAFLD and not really NASH, and F3, F4 fibrosis tends to be maybe 3 to 5% of the population. But when you look at mortality, patients with significant fibrosis, those with an F2 greater than F2 fibrosis, what you will see here is that the mortality is higher. The survival rate is lower if you look at this Kaplan-Meier curve, especially if one reaches F4. Therefore, these are the individual starting from F2 to F4 wherein intervention has to be done. This also happens among patients with lean NAFLD. In this particular study coming from Japan, you will see here that patients with lean NAFLD, some of them may have severe fibrosis. And among the risk factor as risk that they look into, the NAFLD fibrosis score may actually happen. It may be increased. So NAFLD fibrosis score is also one way of checking for fibrosis in the liver non-invasively. I will talk about this in the next few slides. So Clearly, when you talk about NAFLD, histology is the best. We should be able to diagnose whether they have NAFL only or they have steatohepatitis, because for steatohepatitis, we expect inflammatory cells. Apart from that, some other injury like ballooning with or without fibrosis. And there could be some clinical predictors of NASH in patients with NAFLD. Let's say, for example, advanced age, those who are elderly, those who are more than 60 years of age, the gender, postmenopausal women experience accelerated disease, race, Asians, Hispanics, those with hypertension, insulin resistance, or diabetes tends to have a greater rate of NASH as compared to those without them. Clearly, AST over ALT of greater than 1, this would signify cirrhosis. This is the ratio. If it is reversed, we usually expect the ALT to be greater than the ALT. But if the ALT is greater than the ALT, then this is an indicator of NASH cirrhosis, or those with persistently elevated ALT, because ALT is a marker for necroinflammation of the liver and hence inflammation. So who is at risk for NASH and advanced fibrosis? Well, according to this, the AASLD recommendation, we know that the NAFLD, type 2 diabetes individual, patients who are obese, with dyslipidemia, with metabolic syndrome, or polycystic ovary syndrome. So AASLD recommendation, in type 2 diabetes, suspect NAFLD and NASH and determines patient's risk and advanced fibrosis. So all patients with type 2 diabetes, we need to check for the risk of advanced fibrosis. And the greater number of metabolic disease, the increasing risk of progressive liver disease as well. For the EASL, NAFLD screening recommended in persons at high CVD risk, including type 2 diabetes and metabolic syndrome. Now, this is the most common way for us to know whether the liver is getting inflamed. And this is we use transaminases. Well, this is just to show you that this is a very unreliable test. Plasma transaminases are not good predictors of severity of liver disease, high, and therefore they should not be used as a standalone clinical marker. In fact, for individuals who are greater than 45 years of age, I think plasma transaminases is not a useful indicator at all, mainly because a normal value does not mean there's no fibrosis or there's no inflammation in the liver. So what do we do about it? There are some, of course, some non-invasive tests where we can actually use. Very simply, we can use the APRI score. APRI score is very simple mathematics, AST of the patient over the AST upper limit of normal, overall divided by the platelet count of the patient multiplied by 100. If the APRI score is 1.5 and above, then it means significant fibrosis. If 2, then the patient has cirrhosis. This has good diagnostic utility for predicting severe fibrosis, cirrhosis, or low risk of significant fibrosis. Now, there are other ways of non-invasively testing for fibrosis, like the FIB-4 score. This is easy to use, quick, inexpensive test that provides the result immediately. Results are generated utilizing age, AST, ALT, and FIB-4 score, you see here, less than 1.445 excludes significant fibrosis and greater than 3.25 confirms cirrhosis. And the formula is as follows. You don't have to memorize the formula because even for FIB-4 score or NAFL fibrosis score, you can just download a medical calculator and type in the values and the value will come out. So for NAFLD fibrosis score, less than negative 1.455 is a predictor of normal liver, and greater than 0.675 is the predictor of presence of significant fibrosis. And as mentioned, you can just download the medical calculator and type in the value and it will automatically give you the score. So how do we use this NAFLD fibrosis score and FIB-4? Well, if you look at this, NAFLD fibrosis score looks at certain parameters, like 6 or 7 parameters, and FIB-4 score, because 4, they only look at 4 parameters. Now, the good thing about this is that if the value is low, then clearly they do not have significant liver disease. If the value is high, there's high probability of having F3 and F4. But the major issue remains, how about those in the middle? That is the biggest question. This is the question that is difficult to answer based on this test alone, because the intermediate ones are the ones that are more difficult to look for. And therefore, we may do some other tests like using transient elastography to measure the stiffness of the liver, and this is measured by kilopascal. This is a non-invasive technology. All they have to do is put a probe and then just measure the stiffness of the liver using the transient elastography machine. So from a practical standpoint, when we suspect NAFLD on all patients, for example, with diabetes or with metabolic syndrome, then we calculate the NAFLD fibrosis score. If it is low, then they do not have fibrosis. If it is high or it is intermediate, then we subject them for transient elastography. And depending on the result, if the results are indeterminate, that's the time that we may suggest liver biopsy. So, knowing now that the patient may have NAFLD or they have NAFL fibrosis, we try to manage these patients based on looking at simple obesity as the main reason for everything. And of course, simple obesity translates into liver steatosis and finally oxidative injury developing steatohepatitis. So if we can just stop obesity, then we don't have problem with insulin resistance, then steatosis doesn't occur, then we don't have to worry about oxidative injury. So therefore, when we talk about obesity, we talk about weight loss. And this is the weight loss that we want our patient to achieve. If your patient already has fibrosis, we want a weight loss of at least 10%. If they have steatosis, 3%. But in general, I don't know. In any particular individual, they may have steatosis, they may have inflammation, or they may have fibrosis all at the same time. So therefore, I always tell them to lose weight at least 7 to 10%. But the major issue here is not only the amount of weight loss that they need to achieve, it's sustainability. It's very difficult to continue on with the weight loss, especially if you have good food most of the time. And therefore, the sustainability is an issue. If you look at this, those who are achieving weight loss of more than 10%, percent of patients sustaining this weight loss is less than 10%. And this is the basic guidance according to the AASLD that reducing calories is important. Weight loss generally reduces hepatic steatosis, achieved either by hypocaloric diet alone or in conjunction with increased physical activity. We want a 7 to 10% weight loss, and this improves histopathology, including fibrosis. Now, there are a lot of macronutrient diets that are available, but really we don't have prospective trials on all of this because of the studies are limited by a lack of sufficient power, as well as there's no pre-treatment and post-treatment histopathology. Because in the liver, I think the most important measure of liver damage is using biopsy. So the summary for weight loss, we counsel all patients on healthy lifestyle with diet, exercise, and lifestyle, of course. Reducing the amount of calories that one takes and moving more. We consider adjunctive pharmacologic approaches among all overweight individuals with a BMI of greater than 27 and surgical approaches in otherwise eligible obese individuals with a BMI of greater than 35. Diet and exercise, lifestyle, 5 to 8% weight loss, this is difficult to sustain. For pharmacologic approaches, this requires continuous use. And for bariatric surgery, although this can be sustained over a long period of time, we are worried about the complications related to bariatric surgery. But of course, for those who are truly morbidly obese, then this is probably the only way to treat them. The degree of weight loss correlates with NASH improvement, likely regardless of method of weight loss. So, my take on this, suggested ways of losing weight, I believe that increased consultation time would be wonderful for patients. It's very similar to when we talk to patients regarding they have hypertension or they have other diseases, diabetes and that. They need to understand that their disease will not go away, and therefore, they need to understand that even if they are asymptomatic, they need to continue with the way they are with the management. Increased consultation time with emphasis in weight loss as the primary treatment for patients with non-alcoholic fatty liver disease. Maybe we can use a weight diary. This would tell the patient whether they are gaining weight, they're losing weight, instead of just checking this every 6 months or every year. We know that when we talk about non-alcoholic fatty liver disease, from the beginning, we understand that it is multidisciplinary, and maybe nutrition counseling would also be able to help. Low sugar diet, low carbohydrate diet, and fat diet may be ideal. Of course, we encourage physical activity. And at the end, we want somebody who is a determined patient, because these are the patients who are more likely to maintain adherence with regards to their weight loss, and they tend to achieve a negative caloric balance. So, but apart from this, we can give pharmacological effects of pharmacological effects of medicine. Let's say, for example, we want dietary weight loss, medications associated with weight loss. We can give Orlistat. This is the one that is available. We can try to give pentoxifylline, because pentoxifylline reduces TNF alpha. And if you have reduction in the tumor necrosis factor alpha, less inflammation in the liver. TZDs by reduction of adiponectin. Dietary weight loss, reduction in fructose diet, TZD, metformins, and vitamin E can be used for this purpose to be able to reduce the oxidative stress. So therefore, if you look at certain studies, like this is a landmark study, the PVEN study, comparing now pioglitazone and vitamin E in patients with NASH. But if you look at the population that I included here, these are patients biopsy-proven NASH with no diabetes or cirrhosis. So what you get here are reduction in steatosis, improvement in the fibrosis, lobular inflammation, hepatocellular ballooning, and resolution of NAS as compared to those of placebo. But even though they are statistically significant, like lobular inflammation and hepatocellular ballooning and all of this resolution of NASH, the absolute number is still not high. But still, we can use this for this purpose. And right now, I was saying a while ago, there's a lot of science going on, especially with the management of patients with NAFLD. And this is an evidence to this. You can see here that a lot of medicine are being tried for NAFLD depending on the target that we want. Let's say we want to target insulin resistance, targeting lipotoxicity, inflammation and immune activation, targeting cell death, and so on and so forth. And some of these are already in the phase 3 study. And we hope that this is a positive result, so that we can have something positive when we talk about management of patients with NAFLD. But what about hepatoprotectants? Maybe because some of us are probably a skeptic about this because of the lack of large-scale randomized controlled trials. Recommendations for its use in NAFLD and NASH has not been well established. However, there's also no literature that has stated that it is contraindicated for patients with NAFLD and NASH. So, silymarin is a pharmacologically active compound with many properties that have the potential to improve liver diseases of various causes. Unfortunately, well-controlled prospective studies are missing to document its clinical efficacy, and maybe because of the limited bioavailability of oral silymarin that limits its use in medicine. Maybe, if we improve the preparation and we improve the bioavailability, probably we can bypass this problem. And this is where phosphatidylcholine comes in, because we know that silymarin is poorly absorbed by the body. Now, phosphatidylcholine, on the other hand, when taken orally, is well absorbed, up to 90% in 24 hours when taken with meals. Then, if we combine this, we know that phosphatidylcholine is part of the biological membrane and the principal phospholipid circulating in the plasma. So what if we combine this? An amalgamation of silymarin together with phosphatidylcholine, then we have something called a phytosome, and this phytosome may be easier to absorb by the body, and hence we get a better bioavailability of silymarin. This is what we can actually try, and it's called the phytosome. So, because of this concept, let us look at a proof that this actually happens, a review of the bioavailability and clinical efficacy of this phytosome, the silibinin phosphatidylcholine complex known as SiliPhos, and this is what we call as phytosome. And indeed, this really happened. If you look at this pharmacokinetic study here, the plasma silibinin level of those patients wherein they were given phytosome was significantly greater by 4 or 5-fold as compared to those wherein patients was given the regular silymarin alone. And therefore, This is a proof of concept that if you combine these two medicines as a phytosome, then you get a better bioavailability of silibinin, and this silibinin may actually work its way through the liver, and inside the liver, it can act as an antioxidant. So let me share with you this study by Carmela Loguercio, comparing silibinin combined with phosphatidylcholine and vitamin E in patients with non-alcoholic fatty liver disease and RCT. So this is a multi-center phase 3 double-blind clinical trial to assess silibinin phosphatidylcholine complex in patients with histologically documented NAFLD. Close to 180 patients were included, and they were randomized 1:1 to either receive active treatment or receive placebo. So the active treatment, they were given silibinin together with phosphatidylcholine as a phytosome. So the primary outcomes, improvement over time in clinical condition, normalization of liver plasma level, and improvement of ultrasonographic liver steatosis, and even the insulin resistance. Secondary outcomes, improvement in liver histologic scores and or decrease in the NAFLD score. I think this is a better outcome as compared to the primary outcome, but at least they actually look at histology as a secondary outcome for this study. So for the primary outcome, almost all of the primary outcome, including the transaminases, the GGT, and the HOMA, improve on those patients who were given treatment as compared to that of placebo. And what is more important here is that when you look at the histology for those in the treatment arm in the placebo group, those in the placebo group, there's no difference in 1 year time with regards to the steatosis, inflammation, ballooning, fibrosis in the liver. They're actually quite the same. But for those in the treatment arm, treatment group, you will see here that more patients have steatosis. That is because they have less inflammation, they have less ballooning, and they have less fibrosis in the liver. So this is a proof that this medicine may actually work for this purpose. So therefore, when we are treating NASH now, especially those with fibrosis, pre-diabetes or type 2 diabetes and definite NASH, I will just go over this left box here. The right box, I will not touch. For the treatment of NASH, we give pioglitazone based on the PIVEN study. We can also give vitamin E for patients who are non-diabetic, but for those who are diabetic, we do not give vitamin E. Treatment of NASH, lifestyle intervention, weight reduction of 8 to 10%. If this is not achieved, then pharmacological treatment or metabolic surgery. For pioglitazone, if there's no response, then we think of second-line treatment. This is a practical way of treatment for NASH. So therefore, in summary, Mr. Chairman, Angelo, practical guides on NAFLD, in my belief, utility of metabolic dysfunction associated fatty liver disease as a diagnostic tool, has certain practical features with consideration on patients who are lean. I think if you're going to use it in the clinics, this is very useful. However, if you're going to do study, maybe this is not so perfect at all. Normal serum transaminases, we know that it's a guide that we can actually say that a patient do not have liver inflammation. But remember that it is not a reliable surrogate for liver damage, in fact, even fibrosis. And a search for fibrosis is necessary among at-risk patients, and currently we have non-invasive tests to do this, even using just laboratory tests like the APRI score, we have the FIB-4 score, NAFLD fibrosis score, and we have transient elastography to do this as well. We recommend to use more non-invasive tests to determine presence of fibrosis, especially among patients who are at risk, those with metabolic syndrome, those with diabetes, and those who are older age. And as it is a signal to be more aggressive with the treatment, or maybe we need to start intervention. Treatment of cardiometabolic comorbidity is mandatory because right now, when we talk about mortality related to NAFLD, more commonly it is secondary to cardiometabolic comorbidity. Most consistent treatment response is actually coming from dietary and lifestyle modification. And of course, weight loss of at least 7 to 10% should be achieved. And it's not only the weight loss that has to be achieved, but sustainability, meaning to say over time, the patient continues to to have that same weight. And finally, a hepatic protective agent like Cilifos with improved absorption may be used as a complementary approach to the treatment of patients with NAFLD. And this silymarin phosphatidylcholine complex with its antioxidant, anti-inflammatory, and its anti-apoptotic properties. With this, I end this talk, and I wish everyone to stay safe and healthy. Thank you very much.
Thank you, Dr. D. So this previously ignored disease is a silent killer, and thank you for giving emphasis on fatty liver. So we would like to again thank you, Dr. D, for your practical guides in the diagnosis and management of MAFLD, or also known as newly coined as MAFLD. So once again, colleagues, keep your questions coming in the Q&A box.